Hello, everybody, and welcome to the John Wayne Cancer Institute Be Inspired webinar. Thank you for being here today. We're really looking forward to hearing what this group of doctors has to say about the work that we're doing at the John Wayne Cancer Institute. This is the fifth call that we have done this year. We took a little hiatus from March to June, as did the rest of the world, but we're back and very excited to hear the speakers today. While we have retooled how we communicate because of COVID-19, we've found that doing webinars like this allows us to have many people who can call in from other parts of the country or the city. And because of that, we've had a lot more people be able to hear our message and hear about the work that we're doing at John Wayne Cancer Institute. We are excited to be adding Zoom and webinar education to our future educational programming. I want to give you a few ground rules for our call today so that everybody's able to hear and that we can ask questions at the end of each doctor's talk. All of the participants in the call will be muted so that we can hear the speakers. Because you're muted, we're not going to be able to hear your voice if you want to ask a question. So it's important that we answer your questions, and we'd love for you to ask questions. But we're going to ask you to do that by using the chat function on the webinar screen. At the bottom of your page, you should see a chat function that looks like a thought bubble. And that's where you're going to type your questions in. And when you do that, I'm going to see that question. I will then ask the doctors, and they're going to respond to everybody so that everybody hears the question and the answer. If for some reason we're unable to get to your question today, I will see some of those questions, of course, and we'll send out an email with answers to your questions. But if you have questions afterward, don't hesitate to email us or call us, your contact at the foundation, whether it be Mike Avila, Mary Byrne, or myself, or just reply to the emails that we've sent to you, and we'll get back to you with the answers to your questions. We have a very interesting hour in front of us. We'll learn about the John Wayne Cancer Institute and St. John Health Center's work in cancer treatment, research, and our vision for the future. We'll also hear about our pivot to COVID-19 treatment and research, which is an incredibly interesting story. So Dr. O'Day will be talking to you about that. We're going to be hearing from 3 specialists and researchers about our work in urologic and prostate cancers, about new treatment options, research, and prevention. You have received bios from us in the mail, so I'm just going to give you a short introduction, which I'm very honored to do. Our first speaker today is Dr. Stephen O'Day. He's the Executive Director of the John Wayne Cancer Institute and Cancer Clinic at Providence St. John's Health Center. He's also the Regional Director of Research and Professor of Medical Oncology. Dr. O'Day is recognized as one of the preeminent melanoma and immunotherapy specialists in the world. He's been a principal investigator on the seminal research projects that brought immunotherapy to mainstream cancer treatments. And this has changed the way certain cancer treatments are treated worldwide. Dr. O'Day?
Thank you, Jean, and thank you all for being here today. This is really an honor, and we've done a few of these, and I'm so glad we're back. I'm going to just have some comments for about 10 minutes about my role as the executive director and helping to lead the institute. I am so excited about this group that you're going to talk to today, or is going to speak and communicate, because this is one of our amazing groups of disease experts around GU, genitourinary cancers. So cancers of the bladder, prostate, kidney, and testis. Are all part of this group's mission, and we were lucky enough to recruit Dr. Tim Wilson, a pioneer in this field and a huge leader from City of Hope. It's been about 5 years or a little more ago, and he has built this team from scratch at our institute. As you may know, we have a hugely developed melanoma team, obviously going way back to the 1990s. We also have a big brain disease team. And this is our 3rd team, and that is the most developed. And I'm so excited for them to share what they're doing. So just a few comments about this amazing, special, magical institute. It is truly a hybrid of the best of academia with the best of community medicine. And cancer is in the community. And the ivory towers of academia certainly deliver very specialized care, but it can be very isolated and not integrated. What happened in 1991 is an experiment. A big world-class UCLA surgical oncology group led by Don Morton came to a community hospital and brought their faculty, their laboratories, and their patients in a community setting. It's been really a love story of success since then as we've developed, and really been a pioneer in how to integrate care as we've brought medical oncologists and surgeons together shoulder to shoulder in the same clinic. This rarely happens where we're small enough where we can have world-class doctors across disciplines, meaning medical oncologists, surgical oncologists, and radiation oncologists, seeing patients one-stop shopping in the clinic. And so really our vision for now and the future with your help is to build these disease-specific integrated teams. The power of this integration for the patient care is really extraordinary. And I can tell you I've been in different settings, academic settings, pure community settings, and this hybrid setting. And there is no better patient care than when world-class disease experts are talking to each other in front of the patient and behind closed doors about how to best approach the care. It's integrated, it's very, very high level. So what we're trying to do is build these world-class integrated teams, and then we're combining this with cutting-edge clinical trials, bringing the best new drugs to the patient, as well as developing databases around these diseases and specimen repositories. And that's been our strength at the John Wayne. We have developed biorepositories, meaning tumor tissues and bloods from patients that span 40 years, particularly around melanoma, but now we're doing it around these other teams. So each team is giving you the best possible clinical medicine, but they're also creating their GU or melanoma or brain tumor databases. And many patients are offering to participate in this and allow us to follow them in terms of how they do, and pairing them with blood specimens and tissue specimens from their tumors so that we can do science with our scientists, and not only our scientists within the Institute, but also around the world, and we're doing that. So let's just quickly pivot to COVID. Why would a cancer center be at the forefront of COVID research? It's because viruses and cancer are intimately associated with the immune system. And and the cancer community in general has been leading with our infectious disease colleagues the whole access to clinical trials. And because of our background at the John Wayne, we literally have been able to pivot and bring 5 or 6 of the top clinical trials in the world to our center, and led and helped lead the world in bringing remdesivir, a new antiviral, as well as anti-inflammatories already to patients in terms of efficacy. So that's what we're doing. We've also created a COVID, just like we do with cancer diseases, we've created a COVID clinical database, and we're collecting blood on all of our COVID patients so that we can store these and then collaborate with the best scientists around the world. So I want to finish by just talking about this GU team. You know, melanoma, we've been integrated for a while. The brain tumor team's been integrated, but I've actually learned a lot from how Tim has built this team, because he's built it slightly different than us, and really brought a level of integration that maybe we have more to learn to in some of our other diseases. Dr. Linehan is a surgeon he brought with him. He's going to talk about that. And then Dr. Twardowski, one of the medical oncologists from City of Hope, was recruited. This team they're openly collaborative. They're just great people. They're working with our scientists. They're bringing clinical trials to the clinic, and I'm learning a lot from that. And I want to just give one example. You know, there was a need around prostate cancer. There's a lot of competition in our community around imaging, and there's what's called PET scans that we use very frequently throughout cancer. These are radioactive sugar isotopes that where cancers pick up sugar more than normal cells. It's a way to pick up hotspots for where cancer may be that we don't always see. In prostate cancer, the PET scan by itself has been not as effective, but there's a new technique of a different isotope that's much more specific for prostate cancer. And big academic centers had obviously been looking at this and bringing it. Our competitors had brought it into some of their clinical program. But Tim and his group, along with Dr. Twardowski, our medical oncologist in GU, and then our radiology group at St. John's, a very high-level group, have worked together to fight for access to this clinical trial. And when you're outside of an academic area, you have to have a track record. We have that track record because of our success to date and a belief that this hybrid system is leaner and meaner and more effective. And we leverage, just like we did with the COVID clinical trials, we leveraged that history with this group. We got into this trial even a little bit late. And lo and behold, we've put, I think, about 21 patients on the trial. This is a global international prestigious trial, and we're the #1 accruer to this trial worldwide within just 2 months. And not only is it moving the science and a very exciting imaging technology forward, but it's helping Dr. Wilson and his team make decisions about treatment. And so it's bringing value to patients. I think this says it all about what we do. It's a prime example, both COVID and this, where we have the ability to make a difference by bringing the best together, working better, and being small enough to make a big impact, which gets to you all. Please know that anything you do for us, whether it's promoting us, talking about us, referring us patients, giving your dollars towards our research, it has a much bigger impact, I think, in this setting than many other bigger institutions because of what we're doing on the ground floor, working collaboratively across disciplines. And we're just so appreciative of your support any way you can give it, but mainly learning about what we're doing. So I think I'll end there and just, I can't wait to hear what this group has to say.
Thank you, Dr. O'Day. And there's a question, a two-part question. And I'm just going to, looking carefully at this question so I say it correctly. When people have cancer, it often goes from one place to another. So when you talk about collaborative work, are you talking about across specialties? It's not just within your GU, but then if it goes elsewhere, then you would bring another specialist in the clinic?
Well, GU teams or disease-specific teams generally take care of the illness of the cancer from beginning to end, whether it's early or more advanced stage. But I think the new model we're trying to do is sometimes in other models, surgeons may be involved with the initial surgery, but not so much later on if the disease progresses. And what we're finding is these collaborative teams, so surgeons, radiation, and medical oncologists around, for example, GU, they're so integrated that yes, there's a quarterback at each stage of the cancer, right? So a surgeon tends to be the quarterback early on, and medical oncologists later on. Radiation therapists can come and go. So there's always quarterbacks, but the disease teams across disciplines need to stay integrated because it turns out as the science and the advancements are, surgeons are more involved in later stage disease than they used to be. We need tissue at different times, even when the disease is very advanced. And it's so, and you can't always get the goodwill of in other institutions that I've been in. It's not as easy to get people to jump in when they're outside of their norm. But because these teams are small and integrated and people want to be here for this very reason, I find that it's much more open to the collaboration.
That's great. Thank you very much. Okay. We are now going to hear from Dr. Wilson, our second speaker, Dr. Timothy Wilson. He's professor and chair of urology and urologic oncology at John Wayne Cancer Institute. He is also the director of urologic oncology research. Dr. Wilson came to us from the City of Hope and is a world-renowned expert in minimally invasive, laparoscopic, and robotic-assisted urologic oncology. He's one of the top 6 surgeons in the world in terms of volume performing robotic-assisted laparoscopic prostatectomy. Dr. Wilson?
Thank you, Gene. I am off mute. Can you hear me okay?
Yes, absolutely.
Okay, great. So thanks for those kind words, and thank you, Steve. And thank you, those in the audience, for your time today, spending time with us, learning more about the Cancer Institute here and the work that we do. And along the way, I'm going to talk about how our program has developed over the next 10 minutes, talk a little bit about some of the things that are available for screening and diagnosing prostate cancer and treatment of prostate cancer, and along the way, talk somewhat about different funding opportunities that we have that would apply to what we do, but also the Institute across the board, if you're so interested. So as mentioned previously, I came here in 2015. I'd been chief of urology at City of Hope for 25 years. I came here because of the opportunity to work in a cancer institute that was smaller but nimble and could get trials done, and I thought could really be at the state of the art within a short period of time. The program we had at City of Hope, it took me about 25 years to build, and I think we're a good ways along the way here. It's not happening quite as quickly as I'd like it, but we've made a lot of progress. As was alluded to earlier, Dr. Linehan is someone that I worked with at City of Hope, and I was able to convince her to join me here. She's been wildly successful here in Santa Monica, and she joined me in September of 2015. I arrived in April, a few months earlier. Shortly after that, Dr. Movassaghi, who you will also hear from today, I didn't previously know Dr. Movassaghi, but he is just a super urologist, extremely well trained both at Stanford and USC, and is head of the men's health program at Providence St. John's. And it was clear that we wanted to incorporate him into our practice, and we're overjoyed that he was that he elected to do that. You'll hear from him today. Also in 2016, we started something that's really quite special, and that's our minimally invasive and robotics fellowship in urologic oncology at the John Wayne and at Providence St. John's Health Center. And last year in 2019, the family of Mickey Kahan, after his passing, led by his son Alex and his widow Lynn, developed a strategy for raising money, for approximately $2 to $2.5 million, as an endowment for ongoing training and research that our fellows do. And they're just, I'll bring this up again later at the very end of my 10-minute talk, but the fellowship is something that is really crucial to our development, our research, and our ongoing success here in Santa Monica. As Dr. O'Day said, Shemek Twardowski, I had worked with at City of Hope as a colleague and a friend. He's a leader in medical oncology and urological malignancy. And we are overjoyed that he's here. He's been here now just about 3 years' time and has had a tremendous impact. And it's because of him and his leadership that we were able to bring that PET scan study that Dr. O'Day was alluding to earlier. And also we work extremely closely with Dr. Dave Hoon, who's been at the John Wayne for now over 30 years and has had an incredible track record that's really unsurpassed by other individuals in the world getting funding from the National Cancer Institute and the NIH, and has worked closely, of course, back in the 90s with Don Morton. So I'm going to switch gears here a little bit and just talk a little bit about urological cancers and their importance. Very few people really know that urological cancers account for about 30% of all cancers in men, and about 20% of all cancers if we combine men and women. In fact, urological cancers, of course, include prostate cancer, urinary bladder cancer, kidney cancer, testicular cancer. Urologic oncologists like me and Dr. Linehan also do things like urinary reconstruction. We build new bladders for people or put the urinary tract back together if it's been altered or changed or damaged in some way. I'm going to talk more. I'm going to focus a little bit more on prostate cancer and just point out that prostate cancer still is the most common cancer in men in the United States. There's a lot of confusion about it in terms of whether or not we should screen for it, should we treat it, and I'm trying to elucidate a little bit of that for you in the next couple of minutes. So there are over 200,000 cases of prostate cancer diagnosed per year, and it is still the second leading cause of cancer death. Now, the most common way of finding prostate cancer and diagnosing it is getting a blood test called a PSA. And PSA, which stands for prostate-specific antigen, is a protein made only by the prostate. And in the early 90s, we had a number of 4 as the normal amount of PSA. And if anybody had a PSA above 4, all those men got biopsied. We now know that we were biopsying way too many men unnecessarily. And there are some newer tests that we now use in addition to PSA to help us really tell which men need to have or should have a prostate biopsy. One is a test called 4K, and this looks at 4 different kallikreins or molecules, proteins that are called kallikreins. PSA is one of them. And this 4K test combined can give us a likelihood, a percentage that a gentleman has prostate cancer, and also an additional percentage that he has a cancer that would require treatment. Along with that, there's a newer test that's done on urine after a prostate massage. It's referred to as Select MDX, and this is a test that can be collected in a small sample of urine after the prostate's examined by the urologist. That urine is then tested for 2 different markers, and they're highly selective for telling us which men have prostate cancer. In addition, we also use MRI. Now, magnetic resonance imaging, or MRI, is a test that has been used for prostate for many decades, but over the last 5 to 7 years, it's really become essential, and it's changed. It's a very complicated MRI. In an MRI of the prostate, there are generated almost 3,000 images, and it takes a special radiologist to actually read the MRI accurately so we get the most amount of information. And in fact, I'm going to mention a funding opportunity for those that might be so inclined. We have the opportunity actually to recruit probably the most famous urological radiologist, the guy who's been responsible for developing MRI as it is today. He lives in Santa Monica. He practices not very far away. We have a great relationship with him. We'd like to bring him here, and he's interested. And so come talk to me if you'd like to, if we can figure out a way that we can get this guy here. It's really all about money and opportunity. So what MRI has done with us is allowed us to do more targeted biopsies, more specific biopsies that can find prostate cancer. It's referred to as a fusion or targeted biopsy. And this biopsy then, after the MRI is done and sees a spot on the prostate, fusing or digitally bringing images together with ultrasound and MRI, we can find that target on the prostate, biopsy it specifically, and then understand if there's cancer there or not. And then the pathologist looks at those slides and can tell us whether or not there's a cancer there that needs treatment based on its aggressiveness and the volume of the cancer. And we have that technology here. It's the latest technology for what's referred to as a fusion biopsy. Something that I've always been interested in is minimizing the side effects of therapy. And in prostate cancer, that's especially important. We're not only trying to cure the cancer, but we're trying to do it in a way that has minimal effect on bladder function, such as incontinence and erections or erectile function. So how do we do that? Well, the first thing is to analyze the biopsy, as I was referring to earlier. That biopsy analysis tells us something called the Gleason score. And the Gleason score tells us the aggressiveness of that cancer and its ability to grow and to spread, and can tell us whether or not that cancer truly needs treatment. There's another newer genetics test, which I use commonly, called a Decipher test. It's made by a company in San Diego called GenomeDx. And they look at a small panel of genetic markers to tell us the true aggressiveness in addition to what the pathologist sees under the microscope. And this also can give us important information as to whether or not that gentleman truly needs aggressive treatment and can lead to us making the right decision for the right treatment. So I'm going to talk now about some new technology also that's coming along that we believe we're going to obtain here soon. Another potential funding opportunity for you if you wanted to participate, and it's referred to as nanostring. Now, I'm not a scientist, but what nanostring does is allow us to look at pathology slides along with the pathologists, mark out areas on the slide of cancer, and mark out areas on the slide that are referred to as stroma, or the surrounding tissue of the cancer, kind of the nurturing cells of the cancer. And by analyzing those with literally thousands of genetic markers through this technology nanostring, we'll be able to better analyze and figure out how cancers are going to grow, spread, and therefore how better we can treat them. This is about a $300,000 cost to bring nanostring to the John Wayne Cancer Institute. And it won't only be me in urology, Dr. Linehan, Dr. Movassaghi using this technology. It'll be the entire institute. So let's say we have somebody that has prostate cancer. We've analyzed how much it is, what the aggressiveness is. I won't spend a whole lot of time on this, but just suffice it to say that this is a very difficult decision for men to make. Oftentimes, if they meet the criteria, we monitor it, and that can be done safely, and we go through that. Sometimes just focal therapy, treating just part of the prostate, like would be analogous to a lumpectomy in breast cancer, and I think Dr. Movassaghi is going to talk about that. We offer brachytherapy, which involves putting radioactive pellets or seeds inside the prostate. We offer external beam radiation therapy. And we also, of course, offer robotic surgery, which is what I'm a specialist in. And I'm proud to say that when we were at City of Hope, we were the busiest robotic surgery program in the world for a period of time. And really what robotics did was led to an incredible transfer of knowledge across the world. Now, at St. John's, we do have the latest in robotic technology, except one. And this is, I'm going to mention another funding opportunity. This is about a $2 million cost. It's the latest robot. We don't have it here yet. It's called single port. And it involves doing all the surgery we now do through 6 incisions through 1 incision. This has to do with technology that allows the arms and the telescope of the robot to act kind of like spider legs. The instruments come in through one port that's about 2 inches wide and then fan out, and they can get around nooks and crannies and do the same exact surgery we would do with a big incision or with multiple ports. It's extremely exciting technology. We'd like to have single port technology here to improve how we do the surgery with less side effects. Finally, I'm going to just talk, finalize what I was going to say about funding opportunities within urology and urologic oncology. I want to revisit nanostring because this is something that can be used on biopsies and final pathology specimens to help perform more research, to understand cancer better, and also to help direct therapy. I want to mention just cell-free DNA, and Dr. Linehan's much more of an expert with this than I am. But cell-free DNA refers to little pieces of DNA that break off from tumors that float in the bloodstream. And Dr. Hoon, for instance, in our laboratory that leads much of our science here, is a world's expert with cell-free DNA. He's also a world's expert with circulating tumor cells. These are cells that are released from the cancer into the bloodstream that we can actually find and isolate each one individually. And we can identify where that cancer is coming from. And we can also then use that potentially as a tool for screening to see who's got cancer and screening to see who's responding to treatment. We've actually, Dr. Hoon, along with a German engineer named Klaus Lucke, developed a wire, a probe that you can put into a vein and collect. It can grab using antibodies, circulating tumor cells, And we think this is a groundbreaking technology that can help solve many problems of diagnosis and also monitoring and finding recurrences earlier. Also, I want to remind you about the opportunity to recruit an individual that I think is the best urological radiologist in the world from just our own backyard, that would put us on a whole different level than anyone else, certainly in the United States and around the world, for that kind of just building our team even further. And finally, I want to just talk a little bit about the young talent. This refers to our fellows. These are fully trained urologists, usually the cream of the crop. Our fellow this year, Jeannie Sue, grew up in LA. She just finished her training at Yale. She's spending a year with us. We need to find ways of incorporating these young physicians, these young specialists in urologic oncology into our practice here. And that's a goal of mine as we expand this practice to, this is exactly what we did at City of Hope. We developed outside clinics. We brought these young urologists that we had trained. We found the best of them, and they work along with us to build the program. So we have a lasting legacy, and we have a group of people that will build a program that's enduring. So with that, I'll finish. Thanks very much for being here. Thanks for the opportunity to talk a little bit about what we do in urologic oncology at the John Wayne.
Thank you, Dr. Wilson. That was fantastic. I do have a question for you. Is proton treatment still valid for prostate cancer?
Yes. So proton treatment is analogous to external beam radiation or photon radiation. It's usually used only in a few centers. So it works just as well as a standard external beam radiation. Suffice it to say, it's not any better. So the side effects, this has been proven in different studies. Originally, it was thought that the side effects would be less, but in fact, the side effect profile and the surrounding damage to neighboring tissues is about the same.
Great. Thank you very much.
You're very welcome.
We're going to move on to our third speaker today, Dr. Mehran Movassaghi. Dr. Movassaghi is a board-certified, fellowship-trained urologist with Providence Specialty Medical Group. With extensive experience in endourology and men's health, Dr. Movassaghi created a first-of-its-kind comprehensive men's health program in the Santa Monica area. Dr. Movassaghi?
Hi, good morning, or good afternoon. Thank you. I'm joining you from the OR, so I apologize for my OR greens, but thanks for the opportunity. Yeah, so I am Mehran, and I am both the Director of Pacific Men's Health here at St. John's and also Assistant Professor at the John Wayne Cancer Institute. So Tim gave us a really nice overview of both the workup and the screening for prostate cancer. He talked about, alluded to the different types of prostate cancer therapies. So I'm going to spend the next 5-10 minutes discussing some of the new advances that we have here in both prostate cancer and some of the benign conditions that affect men and their prostate. So I think the key that Tim alluded to, and also that I'm going to focus on, is that cancer in 2020 is no longer a one-size-fits-all, and there is no specific algorithm that we need to follow. It's all about personalization, and I think at the John Wayne, that has been an ongoing effort for decades, either with melanoma or breast cancer. And I think we're at that point with prostate cancer. And so, you know, a guy gets the diagnosis of prostate cancer, and it's pretty daunting, especially when you think about historically some of the treatments that have been available for him. But now the treatment that's appropriate for Joe is not what's appropriate for Peter. And some of the tools that we have to use to assess, you know, what is and what isn't, are the MRI findings and whether or not there's bulging of the potential tumor out of the capsule, and some of the genetic tests that Tim talked about. So the Decipher test is common in our practice to use, as well as some of the other tests that really serve as a complement to give us an idea of what are the risks of doing focal therapy or partial therapy, and you know, what are the outcomes. And sometimes, even though we have one of the most talented and pioneers in robotic surgery available to us, that being Dr. Wilson, you know, he would even agree that that may not necessarily be the right answer. And watchful waiting or active surveillance where we can just keep an eye on, the cancer is appropriate, which would obviously have some of the least potential side effects and quality of life. But we've been very fortunate that we can be the first hospital in the U.S. With the help of donor funds to be able to secure the latest in focal therapy for prostate cancer. So the Focal One machine uses high intensity focused ultrasound, or HIFU, in order to be able to treat the prostate cancer only where it is. So, imagine the prostate, it's about a walnut-sized gland deep within the pelvis. So unlike a breast lumpectomy or a melanoma where you can just go and resect the tumor because anatomically it's accessible, we were previously not able to do that. So we were confined in either having to remove the whole gland or treat the whole gland with radiation, proton beam, or whatever types of energy that could potentially have other side effects, like increased risk of other cancers like bladder cancer or rectal cancer. But now with HIFU, which uses ultrasound, we no longer have to treat the whole gland. So if a diagnosis is made and only the left corner portion of the prostate has prostate cancer, then we treat that with a comfortable margin around it. And now we have good data from our own center, and of course from other centers both nationally and globally, that it's safe to do for the right patient and effective. So let me talk a little bit about what HIFU is, how it works, and our program here. So HIFU, think of HIFU as being able to focus the ultrasound beams, just like the beams or the rays of the sunlight are used through a magnifying glass to kind of burn the outer edge of a leaf. So by utilizing that energy, we can focus specifically on the area that the cancer resides. So most prostate cancer procedures, either prostate removal or radiation, involve either multiple treatments or they involve a relatively major surgery with a long recovery. HIFU is outpatient. So you come to the hospital the morning of, you undergo a small anesthetic, either general or spinal, and there's no cutting, there's no radiation, there's essentially nothing. And most of my patients that undergo it, when I talk to them in the recovery, they're kind of amazed that they've actually had prostate cancer treatment. So the patient is under anesthesia. We put the Focal One probe, which is a probe that goes in the rectum, and using a robotic arm, the amount of ultrasound energy and also the movements that are emitted by the machine are controlled after we mark out the area that needs to be treated. So like going back to our initial patient that had the small tumor in the left gland, we can use his MRI findings and also the biopsy findings to find that area, mark it out, tell the computer where to treat, and essentially we sit back and let it do its job. So we've had dozens of patients here that have gotten treatments. We have follow-up for them here, and we have ongoing research. We're part of a national task force that is continuously trying to make the program and HIFU more accessible. And what's exciting about us being at John Wayne, and this is what Tim alluded to, is that we really want to grow the program. So, we have one center, we're 3 urologists, but Providence has such a large footprint, not just in the Southern California region, but truly on the West Coast. We're very unique in that. So being fortunate enough to have this program, this machine here, we're hoping that we can grow it, expand it, bring more patients, and really learn more and try to treat cancer with minimal side effects, as this is proving to do. Not all prostate problems though are cancer. In fact, a large part of my practice revolves around benign prostate conditions. So whether they be prostate enlargement or bladder issues related to prostate. And so historically, again, these types of issues were treated with medications somewhat effectively, but ultimately needed surgery. And some of the surgery was potentially debilitating in terms of the side effects. So now, again, we've been able to invest and be able to partner with industry so that we have become a training center for one of the most minimally invasive options for enlarged prostate, that being called the Urolift, which is essentially a clipping procedure that we use very small, about 1 centimeter size clips that can help open the prostate, keep the urine channel open, that we no longer have to deal with the potential side effects of bleeding and other sexual side effects that come when undergoing prostate treatment. We offer Resume, which is steam therapy for treatment of prostate enlargement. And of course, we have all of the other technologies available that historically have been used. But now we're, again, personalizing men's health, personalizing prostate health, so that we can focus on quality of life with appropriate and effective treatment. I'm open to any questions and look forward to hopefully speaking with you more. At our center, we focus not only on just prostate health, but on sexual health and hormonal optimization. And so if there's anything that you guys have other questions about, I'm happy to answer.
Thank you, Dr. Movassaghi. Really appreciate that. There is a question, and if you can't answer that, someone else maybe can. Is the test, the PSMA, developed at UCLA?
Well, I can answer. No, it wasn't. So, in fact, it's become the standard in Europe. It's really the so it's. I'm not sure what Steve would know this. I don't know what the version of the FDA is in Europe, but it's FDA approved in Europe. Was I don't know where, but the PSMA PET scan was not developed at UCLA. I don't know exactly where the development of the antibody came from.
Okay, great. Thank you. And sorry, Dr. Movassaghi, it was a general question and you got it first.
It's okay, no problem.
Thank you.
Gene, there was a question in the chat about a TURP. Would you like me to answer that in the meantime?
Yeah, that would be great, man.
Sure.
You.
So
fantastic.
So one of the questions that was asked was, what is TURP or TURP? So TURP stands for transurethral resection of prostate. It's a treatment that we've had around for about 30 plus years for treatment of prostate enlargement, usually benign prostate enlargement. It is considered an inpatient procedure, although really it's a overnight stay in the hospital. Depending on how big the prostate is and what the anatomy is exactly, patients that require it may need to stay in the hospital overnight. Sometimes it's only half a day. It's where we go in with a camera and we find the area that's enlarged and we essentially scoop it out or shave it down so that it opens up a channel so that the blockage is no longer present. Does that answer your question?
We'll find out in a moment if it doesn't, because we'll have Tom respond to us. In the meantime, Tom, if you could let us know if that answers your question. But in the meantime, we are ready to get started with Dr. Linehan's talk. Our last speaker today is Dr. Jennifer Linehan. Dr. Linehan is on the call from Yosemite today. And we hope that it's cooler there than it is here, but I spoke with her before the call and it doesn't sound like it is. So she has pre-recorded her talk just in case she was unable to get good Wi-Fi there. So we were gonna see her in one outfit, and then if she's answering questions, you'll see her wearing something else. Maybe a great North Face outfit for her camping adventure that she's on. Dr. Linehan also comes to us from the City of Hope and is an associate professor of urology and a director of urology translational research. Dr. Linehan?
Hi there. I'm Dr. Jennifer Linehan, and I'm Associate Professor of Urologic Oncology and Urology at the John Wayne Cancer Institute. And I wanted to say first that the focus of this webinar is really about community. You're meeting with us today as not just our patients or our soon-to-be patients, but really as a part of our scientific community at the John Wayne. And you're here to help us identify and explore better way to take care of patients. This is a setting for you to ask questions and to voice ideas, which stimulates our own scientific thought and helps us work together with you. So briefly about me, I did most of my education at the University of Arizona in Tucson. I did college, med school, and then my urology residency there. After that, I did a fellowship in urologic oncology and robotics at the City of Hope, stayed on with the City of Hope for a little while, and then finally came over here to the John Wayne. And now I teach fellows on how to do robotic procedures and take care of patients with urologic cancers, such as kidney cancer, bladder cancer, prostate cancer, and testicular cancer. Now, at every point in the doctor's career, at every point in our career, we really fall in love with some part of the anatomy or the physiology. And we use that passion to sort of push us to desire to know everything about it. And some of us become researchers, some of us become surgeons, and some of us become oncologists. And my love really is kidneys, bladders, and ureters. So let's start with the ureter. It's this perfect little tube that carries urine from your kidney all the way down to your bladder. And it's a very small, narrow tube. It's delicate, but it is susceptible to its own set of cancers, its stones, and infections. Now, the little ureter tube leads all the way up to the kidney, which is actually a series of intricate caves. And in those caves, you can have more tumors, stones, and infections. And there's actually a robot that was created for lung cancers and lung biopsies that can help us go into this small tube, into these tunnel of caves, and better treat patients with kidney cancers and kidney tumors and stones and infections. And what's so special about the robot is that it actually incorporates imaging that you have on the patient from their CAT scan or their MRI into the robot and helps direct you where you need to go so that you can more precisely treat the cancer and get biopsies. I'd really want to push and focus on bringing this robot called the Monarch to St. John's so that it could be part of our technology here, not only for kidney and bladder cancers, but for lung cancer as well. Now let's move on to the bladder. So we always talk about treatments with patients. We always talk about we're going to treat you with this chemotherapy and we're going to cure the cancer with this treatment, but we don't often talk about chemoprevention. Now, if you think about chemoprevention, it's most of the time patients are taking supplements or other drugs to help prevent cancer. Well, bladder cancer is very unique in the fact that we actually often treat bladder cancer by putting the chemotherapy directly into the bladder. So we put a small tube into the bladder, put the chemotherapy in, let it base in the bladder to treat the cancer, and then the patient's usually urinated out. But we also know about bladder cancer that 65% of the patients will recur in 2 years. So this kind of chemotherapy within the bladder is very helpful for these patients because it does treat the cancer on the actual bladder, inside the bladder itself, without causing the patient any of the normal systemic symptoms like nausea, vomiting from the chemotherapy. So the bladder sort of is a special organ in that sense that we can get direct access to it and treat directly. But what if instead of about treatment or cure, we were going to talk about chemoprevention? In fact, putting compounds or cocktails directly into the bladder to prevent recurrence, and not compounds that are toxic, but compounds that are more preventative. And actually, these drugs do exist, but we need your help to help test them and get them into practice. So for my next update, I wanted to talk a little bit about bladder function. So I often see patients for urgency of urination, frequency of urination, leaking, getting up a lot at nighttime, and a constant urge to urinate. And those patients often have tried medications that have failed. I'll see patients on the other end of that spectrum where their bladder actually no longer squeezes. That could be from having previous surgery, from diabetes, from back surgery, neuropathy. There's a whole array of things that can cause the bladder not to work anymore. So I see both ends of the spectrum. Now, for patients that have overactivity and they're really refractory to medications, I like to use Botox, which we actually instill directly into the bladder, and that helps to calm the bladder. But for other patients, we actually use nerve stimulation techniques. And about 15 years ago, somebody figured out that if you stimulate a nerve in the ankle, that this feeds back to the bladder and calms the bladder. So patients would come into the office, get the stimulation. They'd come in once a week for 30 minutes for 12 weeks. Well, then a neurologist and a urologist got together and decided, well, what if we treated this like a pain stimulator and implanted the nerve into the ankle of the patient, and then they could just do the treatments at home? Turns out this worked really well and has about 75% efficacy. So if you have any urgency or frequency, please come see me about the Bioness trial in our clinic. It's working very well for patients, and we'll follow up and see if you're a candidate. But it started me thinking about the other end of the spectrum of the patients that I see, the patients whose bladders don't function, the patients' bladders that no longer squeeze, that no longer can urinate on their own. And most of the time, these patients are going to have to use catheters for the rest of their lives. And I don't often forget the look of disappointment I get when I tell them that there are really no good treatment options for this. So I started to think about a plan of what if we could do the same thing for patients whose bladders actually don't function. So I got together with some of my partners at Pacific Neuroscience Institute, and we're actually going to create a project where we instill medication into the bladder to help stimulate the bladder, and then actually at the same time do electrical stimulation of the nerves, and hoping that this combination of therapy to help regenerate the bladder as well as stimulate the nerves works to get the bladder functioning again for no matter what reason that it had stopped. So these are some projects that I'll be working on here at the John Wayne Cancer Institute. And I want to say that I feel incredibly lucky to work with Dr. O'Day and Dr. Wilson and Dr. Movassaghi. You know, we work very closely together, and we're teaching each other things and learning from each other, which really creates a lot of collaboration. But I will say that we definitely need your support, because some of these projects will just lay dormant if you don't help us. And we need the help of you, who's our community, our patients, our friends, to push these projects along to help patients really live better lives. So thank you for your time today, and please find something you love about today and let's make it happen. Thanks.
Dr. Linehan, we really appreciate your time, and I'm just looking to see if we have any questions from anybody about your talk, and I'm not seeing any right now. So we don't get to see what you're wearing today. I hope that you have a wonderful rest of your time up in Yosemite. I'd also like to thank everybody for joining our call today. If you're interested in hearing more about John Wayne Cancer Institute, we will be having more calls like this coming up. We're going to be talking about breast cancer and the influence of genetics on September 15th. We're going to be speaking about melanoma and cutaneous skin cancers on October 20th. I recognize also that some of you may have had a difficulty hearing Dr. Linehan, so I'm going to send a link to her talk in an email when we finish this conversation. So you'll get to hear it hopefully a little bit more clearly. And again, if you have any questions, just respond to that email, and we're happy to send, answer your questions for you. Thank you very much, everybody, for being on this call. Dr. O'Day, Dr. Wilson, Dr. Movassaghi, Dr. Linehan, for your time today. And I hope you all stay cool and take care. Thanks again for being here.
Thank you, Gene.
Bye-bye.
Thank you, everyone.